All right, so we're going to get started. It sounds like we have all of our great speakers with us today, and thank you for many of you who have joined us today. As Maggie shared with you, this is a webinar that's going to review the science as well as some background in terms. What I plan to do is just give you a very brief overview of the three-point plan for ending the epidemic. U equals U is something that certainly relates to our second point in the plan. As you might be aware, we started the Ending the Epidemic initiative in June of 2014 when the governor announced his three-point plan. You'll see them on the screen there, and I can read them briefly. The three-point plan includes identifying all persons who are HIV positive who remain undiagnosed. It's a fairly fitting first point of the plan for us to mention today, especially with National HIV Testing Day tomorrow. So cheers to all of you who will be doing great things for that National Day. The second point is link and retain those with HIV into healthcare to ensure they have treatment. This is where kind of the U equals U conversation and discussion really fits into the Ending the Epidemic dialogue. And the third point of the governor's plan is to provide pre-exposure prophylaxis, or PEP, and we often reference PEP as we're talking about the third point of the plan as well. We want to ensure that that's available to all high-risk persons who engage in high-risk behaviors to help keep them negative. And that's anyone who really wants access or thinks that they need access to PrEP. So the goal is to reduce new HIV infections to an estimated 750 annually by the end of 2020. We have several other Ending the Epidemic measures that are coming into play soon. We'll have those posted on our Ending the Epidemic dashboard. And I should also just mention a huge key component to the Ending the Epidemic work in New York State is community involvement, which we're continuing today as we talk about the U equals U discussion. It wouldn't be without the community that we have our Ending the Epidemic plan. Yes, the governor signed on to it, and we're very lucky to have such support. But it was the community's voice that really started this discussion. And I should also make note that Charles King has joined us today and will provide a few comments in just a moment. He was really instrumental in terms of the Ending the Epidemic initiative starting in New York State. So if you go to the next slide, Maggie. Oh, you gave me the ball. I apologize. So we have several expert panelists with us today. Ben Soy is one of our colleagues. Unfortunately, he is not pictured here. But we did have several of our expert panelists join us on our May 15th meeting in New York City. And again, I should just mention that New York City has signed on to the Prevention Access Campaign statement, which Bruce Richmond we're lucky enough to have here with us today as one of our panelists. And he'll talk more about that in detail. The state has not yet signed on to the Prevention Access Campaign, nor have we made a specific statement pertaining to U equals U. But today's webinar is one of the steps towards us kind of moving perhaps in that direction. So thank you for joining us today, and I will be introducing each panelist as we move forward, reading their bios for you one by one. But before we go into our expert panelists, I am going to turn it over to Karen Bevell, who is my partner in crime here in the Office of Planning and Community Affairs. And Karen has done a great job in terms of really keeping our Ending the Epidemic regional groups moving forward, as well as our HIV advisory body, or HAB, which many of you are part of both of those efforts. So Karen, feel free to take it away.
Hello. How nice to have a partner in crime with the same last name. That way, if we need to pass off on who did what, we'll both be safe. So, again, as Karen said, I also welcome everyone on the call. Special shout-out to my ETE group and our HAB members. Hopefully you are all on the call and can definitely receive good information that you can share with your peers and colleagues. This is indeed a unique opportunity to be involved in our discussion and next steps with this exciting U equals U opportunity. And I do look forward to the feedback that will come out of today's webinar. And I encourage you to keep an ear out and a visual out for future dates that will come that will allow us as a state to continue these discussions and engage you even further in the information that you would have learned today. So I thank you all for being on the call, and as Karen says, your community voice at this time I think is most crucial, and we are on the cusp of new things, and the cusp can be a very scary place to be in. So I think the more information and the more talk we can do around this, the better we will be, and we will feel comfortable with our next steps. So with that, I move on for the day. Thanks.
Great. Thank you, Karen. So right now you see on your screen the agenda for today. We've done that first piece in terms of kind of really talking through the context of the webinar, and one of our goals being really, again, to provide you with some of the clinical background and evidence that is available to us as it relates to U equals U, but also to ensure we're starting that community discussion as we potentially explore messaging options. And as Karen said, there'll be further opportunity for our regional groups and our HIV advisory body and others to join in on that conversation. I will just reiterate that today's webinar is being recorded, and once we have all of our panel presentations, we will move on to a discussion and question period at the end of the webinar. We would love if you could submit your questions via chat to Margaret Brown, which she went over those details with you earlier. So thank you for joining us today. I am going to introduce Charles King now to provide us with a little bit of an overview in terms of his perspective, the many, many items that he is involved in. I'm going to read a brief bio. Charles King is one of the founders and president and CEO of Housing Works, a community-based not-for-profit organization that provides a full range of services for homeless men, women, and children living with HIV and AIDS and other chronic conditions. Mr. King served on the governing body of UNAIDS as a member of the NGO delegation to the PCB and was co-chair of the New York State End of AIDS Task Force. He is currently the co-chair of the Ending the Epidemic subcommittee of the New York State AIDS Advisory Council. He also co-chairs Act Now End AIDS, a national Ending the Epidemic coalition, and co-chairs the visioning committee of the National AIDS Housing Coalition, which has produced 8 research and policy summits to generate research on the efficacy of housing as an HIV intervention and to turn this research into policy initiatives. Charles holds both a law degree and a Master of Divinity from Yale University and is an ordained Baptist minister. And proudly my colleague. Go ahead, Charles. Take it away.
Wow. Thank you. Thank you, both of you, Karen. Such enthusiasm for this call. And I also want to shout out to all of the regional groups who are participating. It has been a while since I've had a chance to get around and see you all and see what you're doing, but this is a very exciting moment. As Karen Bovell said, we are on the cusp. If you look at the state's data for 2015, you can already begin to see that we have steeply begun turning the curve towards ending the AIDS epidemic by 2020. We're in conversation with the governor about the rest of state enhanced rental assistance and about an opioid package that will allow him to say that he's done everything we've asked for him to do that's in his power to do to implement the blueprint. And so it's now on us. It's up to us to make it happen. And I believe that what you're going to hear today is the biggest, most exciting new tool that we have to end AIDS as an epidemic. And I'm very proud to say that the Ending the Epidemic Community Coalition in April issued its own consensus statement endorsing U equals U. Let me put it to you really simply. The reason I so passionately believe in this message and would like to see New York State endorse and get it out all over our state, every corner of our state, is because I believe that this is the single biggest weapon we have, new in hand, to make things happen. It addresses why people don't get tested for HIV. It addresses why people fall out of care, why people don't stay durably virally suppressed, and most important of all, it addresses stigma. The biggest single reason people avoid HIV testing and avoid treatment once tested is stigma. And if we don't address stigma, we're not going to see the end. And that stigma is driven by an irrational fear of contagion of people like me, people who are living with HIV. Not only that, but many of us who are living with the virus feel shame about our diagnosis and fear about giving the virus to somebody else, particularly if we're in a relationship with somebody we love. U equals U is something that liberates us, those of us who are living with the virus, from self-imposed stigma, and it has the power to completely and radically change the way other people perceive us. It eliminates shame, it allows us to live normal and healthy sex lives, and gives us a reason to go on treatment even if our own life circumstances make us inclined not to do so. In fact, what we've seen here at Housing Works is using U equals U. Many people become adherent for altruistic reasons, even when self-preservation and self-care don't persuade them to do it. So I just want to welcome everyone to this webinar. We've got a wonderful array of experts to present in the panel that is to follow my comments, and I'm just excited that we're at this moment here in New York State. Back to you, Karen.
Great. Thank you so much, Charles. And that was a great introduction as we move into our presenters for the day. So we have a pretty packed agenda for a 2-hour webinar, but I think we can do it. I'm going to remain positive, not to shortchange any of our panelists, but we are going to try to keep this to 7 to 10 minutes per presenter. And again, we're hopeful that there will be other opportunities as we move forward with this conversation. So our first presenter is Ben Tsoi. Maggie, if you could put the picture up. Thank you. So I have great bios in front of me, and I've done my best to shorten some of them just a bit. So if you're looking for a full bio, feel free to contact Margaret Brown. She can chat it to you. Dr. Tsoi serves as the Acting Director of HIV Prevention at the Bureau of HIV/AIDS Prevention and Control of the Division of Disease Control in the New York City Department of Health and Mental Hygiene. With the HIV Bureau, he oversees HIV testing initiatives and funded HIV prevention programs, such as those for testing, HIV testing, PrEP and PEP, and condom distribution. He also provides technical assistance to CBOs and other health departments on HIV testing and other prevention topics. Dr. Tsoi received his MD degree from the University of Minnesota School of Medicine, Minneapolis, and an MPH degree in public health preparedness and practice from Johns Hopkins. Ben, I turn it over to you. Thanks for joining us today.
Great. Good afternoon, and thank you for having me on this panel. For my presentation, I'm going to present some information that supports treatment as prevention. We'll start with some modeling data, followed by community-level data, and then finally individual-level data. Some early data supporting treatment as prevention are mathematical models, and in a 2009 article, Granick proposed a mathematical model to investigate universal voluntary HIV testing and immediate treatment for ART. And the model suggests that only universal HIV testing coupled with immediate ART could reduce transmission to eliminate HIV by 2020. In the model, mortality would decrease rapidly by having the epidemic beginning to resemble a concentrated epidemic with only particular populations remaining at risk. And eventually, transmission would be reduced to low levels and ultimately to elimination. In this graphical depiction, it shows incidence per year on the y-axis. And as you can see, universal voluntary HIV testing with immediate ART shown in green is the only strategy in this model that can lead to elimination of HIV transmission. The other two strategies did not. And in another mathematical model, Montagnier showed strong and significant association between increased highly active antiretroviral therapy, or HAART, reduced community viral load, and decreased numbers of new HIV infections. They found that high overall correlation was between the number of individuals on HAART and the number of new diagnoses per year. What it means is that as more people are treated, community viral load decreases, leading to fewer transmissions and fewer new diagnoses. The San Francisco Department of Public Health provided some proof of concept to these mathematical models. Looking at the HIV surveillance data, they found that reductions in mean community viral load from 2004 to 2008, represented by the blue bars on the right, was associated with decreased HIV infections shown by the wet square bars. And they suggested that wide-scale ARTs could reduce HIV transmission at the population level. So finally, we're going to move to data on the individual level. The HIV Prevention Trials Network, or HPTN 052 study, provided data on individual levels. It's a randomized controlled multi-center trial to determine whether treatment can prevent transmission of HIV in several different couples. They enrolled over 1,700 couples at 13 sites in 9 countries, with the majority of the couples being heterosexual. And the couples were randomized to either early treatment or delayed treatment. And in this study, only 8 linked partner infections occurred after the index partner was started on ARTs. Half, or 4 of them, likely occurred before or soon after the index partner started on ARTs, meaning that the transmission occurred before there was enough time for treatment to take effect. And the other half occurred after the index partner failed treatment. So conceptually, many would agree that treatment would reduce transmission, but this landmark study definitively showed that starting ART early reduced HIV transmission by a staggering percentage, 93% in this case. And there were no linked transmissions when the index partner was stably suppressed on treatment. Finally, I'm going to conclude with the last study, which is the partner study. It's a prospective observational study at 75 sites in 14 countries, which enrolled 1,166 several different couples, both heterosexual and MSM couples, who reported condomless sex, and the HIV-positive partner was taking suppressive treatment and had a viral load that was less than 200 copies per milliliter. And they used phylogenetic analysis if the HIV-negative partner became infected to see if the transmission was linked to the partner. And after over 1,200 couple years of follow-up, there were no documented cases of within-couple HIV transmission during condomless sex when the HIV partner is virally suppressed. So there are lots of data showing not only in the theoretical, but in the community and the individual level that treating someone for HIV and having them virally suppressed would decrease or end transmission. For our next discussion about U equals U, I'm going to provide some definitions. Viral suppression is defined as when your viral load is very low, less than 200 copies per milliliter of blood. And undetectable is when your viral load is so low that the laboratory is unable to measure it. So that means it's less than 50, 40, or 20 copies per milliliter. But in this discussion of U equals U, maintenance of viral suppression is key. So what have experts and organizations said about U equals U? Well, in 2008, experts on behalf of the Swiss Federal Commission on HIV/AIDS issued a statement that an HIV-positive individual not suffering from any STD and adhering to antiretroviral therapy with a completely suppressed viremia does not transmit HIV virally, sexually, i.e., he or she cannot pass on the virus through sexual contact. In the Prevention Access Campaign's consensus statement noted that undetectable equals negligible risk. Persons living with HIV on ART with an undetectable viral load in their blood has a negligible risk of HIV transmission of HIV, negligible risk of sexual transmission of HIV, and that is in the context of continued reliable HIV suppression. Finally, Dr. Carl Diefenbach, the director of the Division of AIDS at NIH's National Institute of Allergy and Infectious Disease, has spoken about the importance of viral suppression. And in the video interview in October 2016, he noted that 100% of virally suppressed people will not transmit the virus to their partners, and the chance of HIV infection from a virally suppressed person is 0. However, there may be naysayers that says that if there's a detectable virus in people's genital fluid, they can transmit HIV, or that people have blips sometimes, so they can transmit HIV, or that someone with a detectable viral load with an STD or STI can transmit HIV. And it may be comfortable to agree with the naysayers, but what does the data say? The data demonstrate that people with consistent viral suppression just don't transmit HIV. Thank you.
Great. Thank you so much, Ben. And just a reminder, if you do have questions, please type them into the chat box to Margaret Brown, our host. She will collect them, and we will answer as many questions as we possibly can at the end of today's webinar. All right, I have the pleasure of introducing our next panelist, who is Dr. Gina Brown. Gina is an obstetrician and gynecologist, and she joined the NIH Office of AIDS Research, or OAR, as a medical officer to manage biomedical HIV prevention other than vaccines and women and girls research issues. She also provides expert consultation to the New York State Department of Health AIDS Institute HIV Guidelines Program. Before joining the Office of AIDS Research, she served as the chair of the NIH Office of AIDS Research Advisory Council and has chaired the OAR Women and Girls Work Group. Dr. Brown also was the maternal fetal specialist at the New York City Department of Health and Mental Hygiene and an assistant professor of clinical obstetrics and gynecology at the College of Physicians and Surgeons, Columbia University. She served as the Women's Health Director of the Women and Children Care Center at Columbia Presbyterian Medical Center, a clinic that provides comprehensive care for HIV-positive women and their families. Thank you for joining us today, Gina. So Gina, if you are muted, if you could try to unmute yourself. I think we are having a little bit of trouble hearing you.
Does it apply to breastfeeding? Gina Brown, officer.
Can you hear me?
Yes.
Hi, Gina. You can hear me now?
Yes. Yes, thank you.
Okay, great. And is it loud enough? I'm on my headset, so I can always go on my phone.
You sound good.
Okay, good. So the reason why I'm talking about U equals U with the question of does it apply to breastfeeding is that's been a lot of conversation lately. That's been on listservs, et cetera, discussions amongst clinicians, discussions amongst women living with HIV. And I think it's as important as it is for us to understand what works for U equals U, I think it's equally as important for us to understand what some of the caveats may be and where we might need additional information before we just say that it's going to work under all circumstances. So we know it works for sexual transmission. The question is mother-to-child transmission. And I think it's all about the balance. How do I make it go? I am, and somebody is typing. If you could mute yourself, that would be great. So I'm, okay. So that when you look at how well New York State has done with prevention of mother-to-child transmission, So the CDC's goals were looking for less than one case per 100,000 live births. And in 2013, looking at all the numbers, it was half a case per 100,000 live births, which is a real change from 1997. And in 2015, there were no cases born in New York State, so effectively having eliminated mother-to-child transmission through very consistent hard work that needs to maintain. And looking at for all exposed infants, New York State's goals also met the Centers for Disease Control with no births in 2015. Next slide. Mine is, okay. So you may have seen at IAS in 2016, there was a lot of press around this data that showed that HIV therapy for breastfeeding mothers can virtually eliminate transmission to babies. And what it did was it was a project that was done in sub-Saharan Africa, a number of sites. And what they were looking at is mothers who needed to breastfeed anyway because the risk of not breastfeeding is much higher in terms of death from diarrheal disease because they don't have good refrigeration. And so mothers need to breastfeed. And looking at, can you look at very low mother-to-child transmission rates if you give mothers either antiretroviral therapy or give the baby infant nevirapine continued throughout the time that they breastfeed. And what they found is that there were very low mother-to-child transmission rates with breastfeeding. But they didn't have any viral load information on these groups of mothers. And the other thing is, when they offered this to a wide range of mothers, many, many, many women refused to continue on antiretroviral therapy after delivery. It was something they hadn't signed up for, is what they talked about. And they often go other places to be so that they can't really show that they're HIV infected and weren't comfortable carrying the medication. Next slide. So there's been lots of interest about this, and they asked a bunch of providers, do women living with HIV ask if they can breastfeed? And 76% of the providers said yes. And most of them were immigrants, or almost all of them were immigrants, around 41%. And some, very few were non-immigrants, about 33%. And they were asked, do you have patients with HIV who breastfeed despite what you recommend? 33% of the providers said yes. And I know as a provider myself, I would sometimes work with a woman where very long after delivery, you could still express breast milk from her breast. And so despite her saying she didn't breastfeed, you could still find breast milk coming, which made us wonder. Next slide. The patients who want to breastfeed talk about their concerns, and a lot of it is 84% talked about stigma in the family, stigma in the community. Some were afraid they would lose their health benefits because they wouldn't be able to get WIC and things like that. Some were concerned about not being able to bond with their baby. And other concerns they had was the stigma against using formula in society, that people think that breast milk is better for your baby, and if they're not breastfeeding, they would be considered to be not trying to be good enough of a parent. Formula costs were actually pretty low, and breast discomfort was pretty low in terms of patients having concerns about not breastfeeding. But stigma in the family and the community really stood out about patients' concerns about not being able to breastfeed. Next slide. So the providers talked to the people who did a study sent out a survey to a bunch of providers, and they looked at what were some of the thoughts around breastfeeding. And they found that there wasn't a terribly big difference about whether or not you should consider allowing your patient to breastfeed if you were male or female, but the big differences came with people under the age of 30, meaning providers under the age of 30, they were pretty much uncertain. That 30 to 50 age group, about 35% were uncertain, but only 15% said no. And for the people who were over age 50, and these are the providers, about 31%, about a little more than twice the numbers who said no in the over age 50 group, twice as many said no in the over age 50 group than were the younger age groups of people. And so providers. And the thought is that a lot of us who are over age 50 have been around long enough to see what it means when you see a baby who has HIV, where some of the younger folks really hadn't. Academic providers were more likely to say no than community providers, and physicians were more likely to say no than nurses or other kinds of, like midwives and other kinds of care providers. Next slide. You know, there are WHO recommendations. They recommend that women should breastfeed for at least 12 months, but those recommendations are for women who are living in developing nations where there's not good refrigeration, where they can't get good formula, and where the risk of dying of diarrheal disease is much greater than the risk of HIV. Next slide. No, slide before that. Thank you. And they also say that healthcare workers should assure mothers that having antiretroviral therapy will decrease the risk of transmission if they're in that position where they have to mix breastfeed. We recommend exclusive breastfeeding for those women because when you mix breastfeed and you give your child formula and breast milk, there's some alteration in the GI tract of the infant that makes it a lot easier for them to get infected when you breastfeed intermittently and you're giving virus through breast milk. So the thought is you should either breastfeed exclusively or use formula exclusively, but some women have to work, and so they have to do both. And so the recommendation from the World Health Organization is that you have to take your antiretroviral therapies. Next slide. The U.S. guidelines still recommend that women who are HIV infected do not breastfeed, and that's what I'm going to talk about as I finish up. And that because there are safe infant alternatives, safe infant feeding alternatives in the U.S., you can use formula. There's by and large refrigeration. It's not a problem. That breast milk, giving infants breast milk still increases their risk above zero, which is what it would be if you were not breastfeeding in the United States. If you were not breastfeeding and using formula outside of the United States, there's a risk of death from other issues. But in the United States, it's pretty much a non-issue, and so the recommendation is still that women should not breastfeed. Next slide. And so you can look and see what New York's done with virtually no transmissions in 2015, has done very, very well, and how that's changed over time. Next slide. So when we talk about breastfeeding, it's really kind of a balance, particularly in a place like New York that's done very, very well with women on antiretroviral therapy during pregnancy, with prophylaxis for the infant, and with non-breastfeeding. So we have to look and see what that balance turns out to be. Next slide. So there have been a number of studies that were done that looked at what's the rate of perinatal transmission with breastfeeding and an undetectable viral load up to 12 months. And this person in Canada did a summation of all of the literature that's out there that has specifically those things, women who breastfed who had an undetectable viral load. So for the first month, the risk of transmission was 2.9%. And remember, we're going from infants where there is no transmission. What's their risk if they breastfeed for an entire month? And it was increased 2.9%. At 3 months, they measured, and the risk was 3.6%. Next slide. For breastfeeding up through 6 months, the risk was 4%, and then for breastfeeding up through 1 year, up through 12 months, the risk was 5.1%. So you're taking an infant with no risk of transmission who is deemed to be negative at birth, and at 1 month they were over 2%. At 3 months they were over 3%. At 6 months they were 4% of transmission, and at 12 months it's 5.1%. So for us in the U.S., that's a lot when you're going from nothing to some. Internationally, in developing countries, that's not considered to be a large increase because you have infants who have a much greater risk of transmission if you aren't on medication and if you are breastfeeding, or if you do not breastfeed and they have a much greater risk of death, upwards of 5%, and then upwards of much greater than that the longer they don't breastfeed. Next slide. The other issues with breastfeeding is in the data that was done on maintenance and care, 24% of women are lost to postpartum follow-up in 1 year. So you have women who may have been undetectable, but you have no way to track them and make sure they're still undetectable if you lose 24% in the first year. The other thing is at delivery, 75% of women in New York State were fully suppressed, meaning they were undetectable, but at 1 year, only 44% were suppressed. So you're also losing women having full viral suppression, so that increases their risk of transmitting if they're actually breastfeeding. We know that if you stop taking your antiretrovirals, you have viral rebound within 2 to 12 weeks. If a person has mastitis, where they have soreness of their breast, sometimes before you get a true infection where you're showing that you have mastitis that would take you to the doctor, they may have subclinical mastitis, and that increases the kinds of pro-inflammatory cytokines, things that show that there's inflammation in the breast, and that increases the risk of breast milk transmission. If they have cell-associated virus in the breast milk, we know that breast milk virus is associated with virus inside cells, as opposed to when you're measuring the viral load, you're looking at cell-free plasma viral load. That little yellow thing should actually be in the middle, so that what you measure in breast milk is not the same as what you measure in when you're drawing somebody's blood and it looks like they're undetectable. And we also know that there's differences between the two breasts. So one breast may have a certain amount of virus, the other breast may have none or another amount of virus, even if they have a plasma viral load that's completely undetectable. We know that there are mast cells in breast milk. Those are inactivated CD4 cells, which have virus in them, and when you're swallowing virus, it also increases your risk of passing the virus on when you're swallowing breast milk. And we know that when you give antiretroviral therapy, not all antiretroviral therapy goes across into breast milk, and so you may get some but not all, and that may increase the risk of resistance, where it's not virus that's fully attacked by antiretroviral therapy, and that may increase resistance when you're passing on virus through breast milk. Next slide. This just shows that when you give antiretroviral therapy, it decreases the amount of virus in cell-free by looking at the RNA levels in cell-free virus that's being measured in the plasma, but it doesn't significantly decrease it in cell-associated. So if you're looking at ART on the left, big difference in the blue with HIV RNA in cell-free, but not such a big difference in decrease on the right with the orange where you have cell-associated virus. Next slide. So what do we say to patients? There's been a number of articles that have been published on this recently, and what they say is providers should really discuss breastfeeding with their patients. You can't ignore the discussion because people are thinking about it, and you need to make appropriate recommendations. And if they are going to breastfeed, you need to tell them how important it is to maintain themselves undetectable, but they need to know that it doesn't completely decrease your risk or doesn't completely eliminate your risk of passing on HIV to your infants. So internationally, that little bit that's there may be much better than if you are the risk of what happens when you either don't take antiretroviral therapies or the risk of diarrheal disease and death for your infant if you do use formula. But in the United States, that little bit is more than zero, and we have an opportunity to safely breastfeed without, to safely bottle feed without having to worry about refrigeration. And so breastfeeding is not recommended. Next slide. So if you look at this, in the developed world where you have refrigeration, in this case it really is about the balance, and where you could absolutely eliminate mother-to-child transmission by not breastfeeding, the risks profoundly outweigh the benefits. Thank you.
Thank you very much, Gina. That was great. All right, just a reminder again, if you have questions, please submit them through the chat function to Margaret Brown. All right, our next presenter is Dr. Don Desjardins. He is going to be providing a presentation specific to the clinical evidence around injection drug use and persons who use drugs. Don Desjardins has been conducting HIV/AIDS research among persons who inject drugs, or PWID, for over 30 years. He is PI of the Risk Factors Study, which was instrumental in tracking the HIV/AIDS epidemic in New York City. This study has been funded by the National Institute on Drug Abuse since 1983 and is the longest continuously funded study on HIV/AIDS in persons who use drugs. He has conducted HIV/AIDS research nationally and internationally in over 20 different countries. He has served on many AIDS policy commissions, including the U.S. National Commission on AIDS, the New York City Commission on AIDS, and the New York State Ending the AIDS Epidemic Task Force. Thank you for joining us.
Thank you. I'm pleased to be with the group today, and I will see, yes, these slides are working. I'll be talking about whether undetectable equals uninfectious for injecting-related transmission. Is this a yes, no? It's very probably true, but we really have great difficulties in knowing with absolute certainty. There's great problems in trying to measure transmission or lack of transmission when it's a function of probability and not an absolute yes or no. We do have data showing 0 transmissions from HIV seropositive persons at viral suppression to HIV seronegative sexual partners. But we don't have that quantified for injecting-related transmission in terms of the risk behavior of sharing syringes. Sharing syringes is different from unprotected sex because it can occur. Let me go on to the next slide. We do know that the probability of transmission is a function of viral load. It's very high during acute infection when viral load is very high. We know it's fairly low during chronic untreated HIV infection, but it does vary with viral load. People with higher viral load are more likely to transmit than people with lower viral loads. We do have an acceptable level of uninfectious for heterosexual transmission, less than 1 per 1,000 person years of risk behavior from HPTN and also from the partner study. But syringe sharing is not the same risk as unprotected vaginal sex. We should think of syringe sharing as a microtransfusion. It's more efficient for transmitting HIV than heterosexual vaginal sex. Syringe sharing can also be much, much more frequent than unprotected vaginal sex, perhaps as often as 3 times a day for heroin injections and even more frequently than for cocaine injection. There is one current study in the field, HPTN 074, that is trying to measure whether or not people at undetectable viral load transmit through sharing syringes. The results of this study are due in several months. It's based on social networks where one person in an injecting network is at viral suppression. Other people are seronegative and will be tested for transmission. It's being done in foreign sites with incidence rates are much higher than they are here in the U.S. And there are practical and ethical complications. There are the practical complications of making sure people are adherent and staying at undetectable viral load. There are ethical complications of whether or not you provide adequate supplies of sterile injection equipment so that sharing does not occur. This study is also probably underpowered with some provision of needles and syringes. There may not be enough HIV seroconversions to really know what's the probability of transmitting HIV through syringe sharing. The current situation in New York is that we have very, very low HIV incidence. We have multiple HIV incidence estimates in New York State. Using repeat participants in the risk factors study, we found no HIV seroconversions per 100 person years at risk, with a confidence interval going up to 0.9 per 100 person years at risk. Using the slope of HIV prevalence by years injecting, in this same study, we found an incidence of 0.2 per per 100 person years at risk. And using newly identified cases of HIV among persons who inject drugs in the surveillance reports from the New York City Department of Health, we found 0.8 per 100 person years at risk. So we do know that even without PrEP and even without trying to keep people at undetectable viral load, we are seeing a very, very low rate of HIV transmission among people who inject drugs in New York. This is in part due to very, very low rates of risk behavior among people who are HIV seropositive. Among HIV seropositive people who inject drugs in New York City, we found 8% were engaged in distributive sharing, that is, passing on used needles and syringes, so that among people who are HIV positive and inject drugs, less than 1 out of 10 are passing on their used needles and syringes, and only 3% are of the HIV positives were not on antiretroviral treatment. So we're seeing very, very low possibilities of injecting-related transmission, even without knowing that all HIV seropositives are at viral suppression. In terms of what we should be doing for the future, we certainly should advise all HIV seropositive persons who inject drugs to get onto antiretroviral therapy. It protects their health, and it at least reduces the chances of transmitting HIV to others, and also that it's important to take the medications as prescribed and to adhere to their treatment regimens. In terms of future research, we should continue the ongoing studies, and the State AIDS Institute has a Sentinel event project to try to identify risk partners of newly identified HIV infections among people who inject drugs, to determine whether the likely transmitting risk partners were on antiretroviral therapy and at viral suppression. This would include potential phylogenetic testing for confirmation if transmission appears to have occurred when a transmitting partner was at viral suppression. However, this is really not epidemiologic research. This is really case studies. We're down to so few newly identified cases of HIV among people who inject drugs that we'll really be doing individual case histories of what happened. We would not be able to come up with an estimated transmission rate with confidence intervals. Earlier, people talked about stigma, and one of the important factors in U equals U is that it has the potential to reduce social stigma and also self-stigma. We will not know whether this U equals U is absolutely true for injecting-related transmission, but I think it's very important that people who inject drugs should take pride in the accomplishments of the injecting community. The people who inject drugs should take pride in protecting their own health and not feel stigmatized because they're protecting their own health. They should take pride in protecting their sexual partners, and they should take pride in protecting injecting partners because through having good supplies of sterile injecting equipment. That if I'm HIV positive, I should have not only enough injection equipment for myself, but I should have enough sterile injecting equipment that I can give other people sterile needles and syringes. And a final note, we still are greatly concerned about hepatitis C virus. We have a hepatitis C epidemic that's continuing and perhaps even growing with the number of new injectors, so that we need to not only be concerned with eliminating HIV transmission, but we want to try to greatly reduce hepatitis C transmission through sharing of needles and syringes also. Thank you.
Great, thank you so much. What a great presentation. So at this time, we've learned a lot about the existing evidence as it relates to sexual transmission, breastfeeding, and injection drug use for persons who use drugs. So at this time, we're going to hear from Dr. Michelle Cespedes. She's going to share with us some insights from the clinical considerations from a provider perspective. From there, we're going to move on to discuss the U=U consensus statement from the Prevention Access Campaign, and we have the Executive Director, Bruce Richmond, with us to do that. And then we'll move forward with the perspective from community and individuals who are HIV positive in terms of what messaging and what U=U really means from that perspective. So I'll turn it over to Michelle. I'm going to read a brief bio here. Michelle Cespedes joined the Division of Infectious Disease at the Icahn School of Medicine at Mount Sinai as an Associate Professor of Medicine in 2014. Dr. Cespedes received her undergraduate degree in biophysics from Johns Hopkins University. She received her medical degree from Mount Sinai School of Medicine and completed her residency in internal medicine at New York Presbyterian Hospital, Cornell. Dr. Cespedes completed her infectious disease fellowship at NYU. Her research areas of interest are complications and comorbidities of HIV, with an emphasis on HPV, HIV-related women's health issues, and HIV prevention in high-risk populations. There's much more to her bio, but I'm going to stop there and turn it over to Dr. Cespedes for her great presentation. Thank you for joining us today.
Thank you for the invitation. So despite all of my research background, I was really asked specifically to put on my hat as a provider, giving care in New York City, but also the importance of talking about how we actually incorporate the concept of U=U to our everyday lives when we take care of our patients. So I wanted to spend some time actually just going over some of the basics and some of the points that I touch on, not only just with my patients, but also with my students and residents who shadow me and work with me, and really the next generation of providers. Really the most important thing, and I think everyone has touched on it, but really the long-term viral suppression is really how we're going to get to the end of the epidemic. So not just for the people who actually are infected, but for the people who are uninfected to stay that way, right? Think of it almost in terms of herd immunity, but the fact is the way we will do better is to make sure that everyone has access to care and they're actually doing well on it and being consistent with it. Sometimes when I actually see younger people who are newly diagnosed, I always tell them I wish they were my PrEP patient and not my HIV patient, but the good news is that they were born at the right time. There are medicines that work well, that have few side effects, that we've actually had the benefit of research and clinical trials to get people down to one pill once a day. But the possibility exists that even in their lifetime that we will be approaching a cure where they won't have to take medicines every day. But that time is not here yet. So the important thing is to actually get on medicines that work well for you, that you can tolerate when you're ready, and can be committed to taking them consistently and to stay in care. Sometimes often the first question is, Doc, how long am I going to live with this? Or, will I die? And I usually say, not today, but usually more importantly, not because of your HIV. So the other concern that we have to mention also is that despite the access to care and the advances in medicine, not everyone actually is getting the full benefit of the medications. So when I say full benefit, what I explain to my patients is that if you're taking the medicines, I want you to have, all of the good from it, not the side effects and not the complaints. But if you're willing to take the risk of the medicines, I want you to get 100% of the benefit. And the way I define the benefit is really becoming virally suppressed consistently over time and for a long duration. So despite access, especially here in the States, even we have better access here, even in New York, than compared to other parts in the country. But despite this, across the U.S., only a small fraction of people really meet the definition of viral suppression. And that's in the order of 30% getting to targets of less than 200 copies consistently, and even a bit lower if we use the benchmark of less than 20. That's around 25% of people. And then those success rates or those levels of viral suppression, and again, here in New York, we're doing really quite well. Actually, even over in the last 5 years, we've gotten better in terms of the percent of people in medical care who are virally suppressed. So in 2011, here in New York City, that percentage rate was 71%, and all the way up to 83% in 2015. Some reports say 83, some say 87, but that's really quite high, especially better than compared to the 30% nationwide. The issue is that not all subpopulations of people infected with HIV are actually reaching that benchmark. We're seeing especially lower rates in transgender. We see on the order of 74% of those in care are virally suppressed, and some of the lowest suppression rates are actually in adolescents aged 13 to 24. The most recent HIV surveillance annual report data from 2015 had that percentage down to 67%. And even a colleague here in New York City who actually runs the HIV/AIDS Adolescent Center up in Montefiore, only a small fraction, only about 33% of her perinatally infected and very young adolescents were virally suppressed. So there is room to grow. We can do better, and we should be doing better. But part of it is education and letting people know the benefits of staying on meds consistently. So the other thing to do is to actually make sure that we keep in mind, even as providers, we're doctors, we're scientists, we know the rules, that other things come into people's lives that actually threaten not only their ability to get to clinic, but to stay on their medicines and do the things that we would ask them to do on a daily basis. So threats beyond just social determinants of health that I speak about a little bit later, but some of the more common things are really even just mental health, either undiagnosed mental health issues or poor coping mechanisms with the diagnoses they already have. I used to say transportation or just getting to clinic or following directions or access to a phone. We put all these things in place to actually, remind people to come. We connect them with care coordination. And sometimes if they don't have a phone or a consistent address where they can be found or the ability to return to clinic, there's an issue. I take it for granted sometimes that because we live in New York City and you can get a train or a bus anywhere, there shouldn't be anyone who can't get to clinic. Sometimes I am surprised when someone explains to me that, yes, they were late for my visit, but it actually took them 2 hours to get here, where that wasn't necessarily what I was concerned about. And I think something that we don't speak about often is not just domestic violence, but intimate partner violence. A lot of people who don't feel safe, taking their medicines or actually hiding their medicines or finding a safe place to put them can actually be an issue with them as well. And another thing I like to touch base on, partially because of my hat as being part of the HIV Medical Association, a lot of the things that we've been doing lately is actually working on making sure everyone knows that the threat to the the proposed changes in the healthcare landscape can actually threaten one of the things that we work hardest for, is actually getting our patients not just access to care, but consistent access to their medications that they can take consistently. So currently in the U.S., about 40% of those with HIV actually receive benefits and prescription benefits included through the Medicaid program, and the proposed changes would actually threaten that quite a bit, actually, if it does go through. People who don't have consistent access to health and health care really depend exclusively on some of these federal programs and state-based and federally matched programs. So we have to be mindful of how those changes will affect our patients as well. So the next thing I wanted to talk about is actually how we speak to each other may not necessarily be the best way to speak to patients. So health literacy. Because I understand what one word means, it doesn't necessarily mean that another person understands it the way I intend. So one of the things I always make sure that I do is actually make sure that even though we've went over this before, even though I think you know, I always make sure that I talk a little bit about just the principles of HIV treatment, what I'm testing for, why am I taking so much blood, what are the things that I'm looking for, and the job of the medications. So oftentimes when someone's newly diagnosed, it's not unusual for me. Sometimes the nurses laugh at me. I'll actually draw pictures. This is the job of the immune system. This is how HIV medicine work, and this is the reason why I want you to take it. So I always make sure that oftentimes when I see a patient on a routine visit, sometimes I tell them that I'm testing them, but what is the name of your medication? Right? Do you remember your last CD4 count? Do you remember some of the things that we talked about last time? Can you reiterate at the end of our session what we talked about and some of the next steps or things that I want you to do? Reminding people that being undetectable now and doing well now is a long marathon. It's a race. Really, gaps in care and treatment and missing your meds for a couple of weeks can make a big difference, especially at the start of treatment, but even when I think people get complacent over time or over years, or I've missed a tablet here and there and I've missed a weekend and I haven't gotten into trouble. Really, gaps in treatment can cause the changes and just increase in viral loads and risk of transmission to others, and also the inability of your tablets to work if you start and stop them as well. Dr. Brown spoke a little bit about special populations. I always make sure, I think because of my interest in women's health and HIV in particular, that we talk about really special populations. So not just pregnant women and the risk of transmission to their unborn infant, but we've really made significant strides here in the States. It's, really being undetectable is a measure of health, but for you, your family, your future family, or making sure that I address the needs of everyone who comes to my office. And I think sometimes we get lost in doing all the testing, the viral loads, the counts. Are your kidneys okay? Is there anything that I missed? Are there new recommendations? Did I check your vitamin D level? And really don't talk about the main concerns of the patient in front of us, that they may or may not feel, they're either proactive or empowered enough to ask us. The other thing I wrote down here is actually dispelling myths and misconceptions. I can't tell you how many women are surprised when they learn that actually that they can have children and that their children will likely be uninfected if we get them under control. Talking about what undetectable actually means, right? The definition of undetectable. Because you cannot find virus in my blood right now, does that mean I'm no longer infected? If you retested me, I've had several patients ask, if you tested me now that I've been undetectable so long, would that test still say that I am HIV positive? So really talking about what it means to have HIV, that it is a chronic disease, that your body, does its best to try to control the virus, but it's really the job of the medications to suppress the virus consistently over time, which really requires that they be taken consistently over time. And making sure that, both use, what undetectable means to you or what I think it means. Can you tell me in your own words, what your viral load means? What does undetectable mean to you? Actually, one of the providers in a group that I was talking to last week actually told me that she's heard of young men who are actually confused by you because on one of their apps, I believe it was one of their dating apps, I believe it was Grindr, He said that he thought U meant uninfected. All right, so people using the jargon differently or what they believe it means, we have to make sure that we get the messaging out properly and that there's no confusion between us, the providers, and also our patients as well. Again, remembering that we're always in a partnership with our patients and providers. You know, HIV, just its treatment and the knowledge that we have has been just an ongoing steep learning curve over the years. Even though I consider myself one of the younger doctors, things have changed so much over time, but making sure that we still think of ourselves as a partner with our patients on their journey to health, really. So respecting their decisions, respecting what they want, but also giving them the information of new science, new research, and things we learn as we kind of grow up with this disease, the epidemic, and its changing faces over the years together. So I mentioned it briefly a slide or two ago, but really taking into account the social determinants of health. On that bottom right corner, I put a nice little graphic that actually kind of explains some of those things on both the macro level, you know, things in society and infrastructure, and, you know, even sometimes the hospital systems on a larger level, to things that are more personal as we move farther to the right and more intimate, but things that can actually always get in the way of health and are intertwined with both society and poverty and education and things that you know, can impact our health regardless of so many levels in other disease states, but especially important in HIV as well. We actually also have to pay special attention to how we can, you know, we can't necessarily change, you know, the government today or policies, but actually paying attention to things and interventions that we can do and can help. And I wrote down here social integration and support systems. Oftentimes we have clinic staff and case managers and programs, but sometimes even as simple as talking to your patients about their disclosure status. So I was unfamiliar with this, but one of our behavioral researchers and psychiatrists here at Sinai actually showed me some data that actually said that people who do not disclose their HIV status, people who are either more isolated or have more of a sense of shame and stigma attached to it, they tend to be more likely to engage in higher risk sex acts, but also including exchange sex. They're more likely to have either sex with someone that they either paid or anonymous sex, and may tend to have riskier sex because they don't have a close connection, or I'm not sure whether we can say true causality, but there's an association with people who don't disclose their status. But asking that, you know, what is your social support? Do you have friends or a community or a church group, or do you feel connected? Are there groups that you may be interested? Can we help refer you to some of the other groups here? Simple things like that, and asking the questions can actually make a big difference. And again, that comes together with, you know, fostering an environment of the fact that I asked you and the way I delivered the question can actually open up honest lines of communication where people feel like, oh, they're not just asking me, or they think that there's something wrong with me, but, you know, she said it so matter-of-factly. I'm sure she asks this to all of her patients. I remember at the last talk we talked about it, and I especially talk about it with some of my younger students or people who don't do this often. When we go over either social history or even sexual history, you know, I always start with, I'm going to ask you some personal questions now, but I ask first about smoking and then alcohol intake, and then, you know, I think it takes them off guard a little bit. But then we ask about, you know, who do you sleep with? Do you sleep with men, women, or both? Types of sex acts, things that we can actually, you know, teach people about, higher risk acts and things of the sort. But I think people tend to feel more comfortable and are more likely to bring up things or even ask questions that they may have felt uncomfortable or that it wasn't the right place to do it, but feel more open doing it, because I'm exactly the person that they should be talking to this about.
Hi, Michelle. It's Karen. I'm just doing my time check. We have about 1 minute left before we have to move to the next presenter. Thank you.
Excellent, excellent. So you can see on the bottom of the slide, it actually talks about, we spoke about this a little bit, really acknowledgement of sexual health as really a part of being a human being, and it's acceptable, healthy part of not just their sex life, but of their overall health. And as their provider, making sure that they feel comfortable enough to bring up not just only sex acts and who their partners are, but really their desires to have children. Right? Very few providers ask HIV-infected women their plans for having children or next steps, and it really just opens up more lines of communication. So the last slide talks about, and we're going to go back into that a little bit later with some of the next providers, on how we better send messages. And we talked a little bit about just the language that we speak, right? Health literacy and measures of success. I think reminding people that this is going to be a long haul and that HIV is a chronic disease actually puts things into perspective, that this is not just a one-term deal, but that you're actually going to be a partner in care for life. And I think the point on the bottom of the slide where it can really take months to be reliably undetectable, I always tell people that, you're only as undetectable as your last lab result. You can become viremic again in a short amount of time. So just to wrap this up, I think making sure that both provider and patient are on the same page on what U equals U really means, and that I always like to say it's not just about condomless sex, it's really about being part of a whole. And we spoke about, even with Dr. Desjardins' information about the risk with IV drug use and the rising opioid epidemic around the country. We're seeing more and more, not just Hep C, but new HIV infections in places where it is unexpected and where there aren't as many HIV providers. The impact in prevention of mother-to-child transmission, both here and in resource-limited settings. But most importantly, really being undetectable and staying undetectable. I think my last line says it really quite well. It's simultaneously an act of self-love, where we're really working on overcoming stigma and self-doubt and isolation, but really an act for caring for the benefit of the community as a whole, where we talk about ending the epidemic and prevention in and of itself. Thank you so much.
Great. Thank you, Michelle. And I think that was a great kind of transition from, clinical evidence, from research to messaging and relationships between, individual and provider. So now we're going to move forward to our next panelist, Bruce Richmond. He's the Executive Director and the founding Executive Director of Prevention Access Campaign and the Undetectable equals Untransmittable, or U equals U, global community committed to ending the dual epidemics of HIV and HIV stigma by ensuring communications about people with HIV catch up with the science. Before launching U equals U, Bruce founded Inspired Philanthropy Group, which creates cause-related programs for high-profile people and brands to leverage their public platforms for social change. He received his Master's in Education in Administration, Planning, and Social Policy from Harvard Graduate School of Education and his JD from Harvard Law School. So it's our pleasure to have Bruce Richmond here with us today, and I'll give you the floor.
Great. Thanks a lot. Thanks for having me. Can you hear me okay?
Yes, perfect.
Okay, perfect. Okay, let me move past that first slide. So I like to start with this slide because we're really proud of our partners here. You can see on the left is International AIDS Society, and on the right is NAM and AIDSMAP. And both of these organizations are partners with Undetectable's Untransmittable campaign, and they're endorsing the message that a person who is undetectable does not pose an infection risk to their sexual partners. And that is what Undetectable is Untransmittable is all about. Go to the next slide. I think as Charles King said earlier, quite eloquently and in such an inspiring way, this is a defining moment in the history of the epidemic. That 20 years ago we learned that effective treatment would save our lives, and today we know that means that we cannot sexually pass HIV on to others. So why is this critically important? And Charles also earlier very eloquently explained why this is important, so I'll move through this pretty quickly. But the first, for A and B, was enough for me to get involved with this campaign, improving the lives of people living with HIV so that we could have relationships and sex without fear and conceive children without fear and without alternative and costly means of insemination was enough, and dismantling HIV stigma was enough. The stigma on the clinical level, on the community level, on a personal level, on a policy level. So that was really exciting for me, and really was why I got into this. And then once I was in the field a bit more, I learned about C and D, which are huge as well. And again, as Charles said earlier, this is a new incentive to go on treatment and to stay on treatment for our own health and to prevent from passing HIV on to others, which means we'll be healthier and there'll be fewer transmissions. And the last one, which is so important for us to remember, is that this is an unprecedented opportunity to advocate for treatment, care, and services. So not just for our health, not just to save our lives, which again should be enough, but to prevent new transmissions and get us closer to ending the epidemic. So this is the most effective strategy we've ever had to improve the lives of people living with HIV and to end the epidemic. Sorry, it's taking a bit. So here we are, but people don't know. There was a UCLA study based on knowledge up to 2014 that showed between 6 to 14% of people living with HIV who are on treatment believe they can't transmit HIV. And actually, when you think about the latest CDC surveillance data, which is very promising from 2016, the actual numbers is 54.7% viral suppression among people diagnosed and alive at the end of 2013. And in the Ryan White program, it's 83.4% viral suppression among clients. So there are people who, in the United States and obviously all around the world, who believe that they are infectious, and they're walking around carrying this burden, which is unacceptable, and they don't need to. So why wasn't this getting out? So we could talk for hours about this part, and I cut a slide out because it was. I think the important thing is to briefly touch on this, but then look forward. But one of the reasons why this wasn't getting out for years was because science doesn't have a publicist. So you have all these studies on the left-hand side, like Partner and HPTN 052 and Partner's demonstration. And then you have these consensus statements like the Swiss statement, the European AIDS Treatment Group statement in 2015, which unequivocally said someone who was undetectable was not infectious, and we needed to launch public health campaigns to fight stigma. Very strong statement. And the Canadian consensus statement and the context of criminal law. So we have all these, but each of these studies and these reports was sort of publicized independently by the institutions that supported them or the researchers who worked on them. And then you have these journalists who were reporting on the studies, and journalists, we have lots of examples of this, have their own bias and report on studies through their own bias. So your everyday ASO, CBO, public health body would be reading the journals and reports and getting mixed messages about the studies because there was no persuasive conclusion on the aggregate of all the studies. And folks, at your everyday ASO or CBO, they didn't have the authority or the experience to come out and make public statements, put things in writing. People were sort of, saying it. Doctors were, we found a lot of doctors and people in public health who actually knew the science and they agreed with the science, but they would share it on a case-by-case basis with people like me who, I learned in 2012 from my doctor that I couldn't transmit. So they'd share it with people like me, but they wouldn't be sharing it with other people who might be what they would consider the unsophisticated consumer. And the problem with that is that those decisions about who gets to know and who doesn't get to know, that's made through the lens of people's of their intersecting stigma and bias and sex negativity, all kinds of phobias. So, except for the lucky folks like me, most people were in the dark about this, especially marginalized communities who were already neglected by the healthcare system. So this was the big game-changing secret in the field, and it deserved to be shouted from the rooftop. So that's what we decided to do. We decided to become the publicist. We decided to become that loud guy that was going to shoot, use a megaphone and get this out. So how did we get to U equals U? How did this campaign launch and our community push this message out? Well, first we needed to get a global consensus on the clinical and the empirical evidence. So not just clinical, but also the non-observation of any event occurring since the beginning of ARTs. And then we would build support on that global consensus statement from influencers. And then we would disseminate the message to everyone. And we would disseminate, our idea was to disseminate through partnerships with advocates and organizations who could then localize this information and distribute it in ways that work for their communities. So we worked with, over a period of 6 months, with the principal investigators, Myron Cohen from HPT 1052, Jens Lungen from Partner, Andrew Grulich from Opposites Attract, and Pietra Vernazza, who was on the executive committee of Partner and the author of the pioneering Swiss statement. And here's what we came up with. So as Ben mentioned earlier, the consensus statement was based on someone who was on treatment, not long-term non-progressors or elite controllers. They had an undetectable viral load, which Ben described earlier, and then the risk was negligible, and it may take as long as 6 months. And the key is excellent adherence. That's it. The researchers were just concerned about adherence. Stay on your pills, stay on your medicine every day, and your viral load is not going to go up. I know Michelle said earlier you're only as good as your last viral load test. I don't agree with that. I think that puts fear into people's hearts. That just keeps us stigmatized and in terror. Between one viral load test to the next viral load test, we think that the viral load is going to shoot up to infectious levels. It doesn't. If you take your medicine every day, you're going to be undetectable and you're going to be untransmittable. So the key is adherence. Adherence, adherence, adherence. So what does negligible mean? Because a lot of people don't understand what negligible means. It means so small, unimportant as to not be worth considering and significant, and it's the same CDC risk category as spitting and biting and throwing bodily fluids and sharing sex toys. So now we had the consensus statement, but now we needed endorsements. Now we needed the influencers, big influencers, to come on. And this was an exciting time when in July, when New York City, Dimitri Daskalakis signed up New York City. Within 3 weeks, he came on board as the first public official and to endorse a consensus statement, to put in writing negligible risk, and New York City was the first Department of Health to sign up. I'm pleased to announce here to all of you first that DC Department of Public Health is signing on tomorrow at a press conference with the mayor. So DC will be the next city in the country to endorse U equals U clearly, explicitly, unequivocally. And then when NYSDOH signed on, Murray Penner made a bold statement with NYSDOH. It really things moved forward, and Housing Works became the first AIDS service organization in the country. And so we had this muscle of New York City Department of Health, NYSDOH, and Housing Works. New York City was a haven for people living with HIV. Then on the West Coast, San Francisco AIDS Foundation signed up, and when AIDS United came on, we have a solid, very solid core of influencers in the U.S. And then internationally, Katie, ICASO, IAS, and NAM AIDS Map really launched us internationally. And we have a lot of amazing organizations. So those are really the anchor organizations, but there are so many. Positive Women's Network worked with us from the very beginning, and Human Rights Campaign and AIDS Foundation in Chicago. All of these groups, I could go on, and we have wonderful partners locally and internationally. Terrence Higgins Trust is a global leader. So all these groups. So now there's 270 organizations from 30 countries. Those little dots are the countries. And the consensus statement has been translated into full or part into 11 languages. Let's see here. Okay, so this is the fun part. So what is the messaging around the world now? What are people saying around the world? These are all of our partners. This is just a sample of some of them. The first kind of messaging that we got was from the United States. A really important message was from Carl Diffenbach and Anne Rancourt, and Ben showed this slide earlier. This video was very helpful to us in our advocacy in early September. And Terrence Higgins Trust is the global leader on this messaging. They came out with a campaign in September, and they actually have a very strong campaign launching later this week. So New York City, you see, back in December, had treatment equals prevention on billboards in New York Times Square. This was a very exciting time with Housing Works and New York City Department of Health on board. Later on, Housing Works, liveundetectable.org, I think is the best website that we've seen in the U.S. for all that you need to know about undetectable, and I think it's probably the best campaign that we've seen globally too. So liveundetectable.org. Check that out. We actually even danced in the streets with New York City Department of Health and the End AIDS New York City 2020 Coalition. 79 organizations signed on to the consensus statement and created their own very strong, very clear consensus statement in April 23rd. San Francisco AIDS Foundation has a good website. The Well Project for Girls and Women signed on. It's I equals I in Italian, I equals I in Spanish, N equals N in Dutch, B equals B in Turkish. This is the Czech Republic. They're using this for criminalization. It's H equals H in Macedonian. This was our French partner. They just launched the overlay. U equals U is this summer. They're marching in Pride this past weekend, and the Black and White is a campaign they launched in December. This is our partner ACT UP at Dublin, very clear campaign. This is Canadian Positive Peoples. They've been doing training. Canada is going very well. Canada has just really taken off all over the country. And then these are some of our other partners who have created, kind of made this their own. Michael Brady, medical director of Terrence Higgins Trust. Angelina Namiba from Salamander Trust, Matthew Hodson, Executive Director of AIDS Map, and then William Matovo, Executive Director of Love to Love organization in Uganda. And we're almost finished here. And then you can see the rise up to HIV. There are 250 of these so far, of these frames. People have really embraced the campaign in ways that have made it their own. This is everyone's campaign. This isn't our campaign anymore. This is a campaign that's global, and people with HIV all over the world are embracing it and sharing it. And so I like to end on these quotes because this is really what's happening. The world is changing for people living with HIV. Millions of people with HIV, not just people who are on treatment, but people who are seeking treatment or people who haven't yet decided about treatment, and our partners and people at risk for HIV. It's changing the field. And it's the only reason we're here is because people spoke up. Because people living with HIV spoke up, and we had the early adopters speak up, New York City and Housing Works and NYSDOH and our international partners, and everyone that signed up now, all 270 organizations we feel are still early adopters. They're still early majority. So there's still time to get involved and sign up and become a part of this movement and this message. And the easiest way to do it is go to u=u.org, and you can join us. There's lots of ways to get involved, to be advocates, and to also sign your organizations on as partners. Thank you very much.
Great. Thank you so much, Bruce. And really, thank you for sharing the many ways in which, others have taken on the messaging. I think, if and when the state was to sign on to the Prevention Access Campaign, I think messaging is definitely the next step. And also, really great news to hear that Washington, D.C. is signing on. That's fantastic. All right,
great,
so, that's great. So we're going to continue forward. We have two more presenters from the HIV Stops With Me campaign. They're also going to be sharing with us a little bit from the perspective of kind of what U=U means for someone who is living with HIV. And also, you know, we've heard a lot from our you know, New York State hasn't specifically signed on to the statement, but New York City has, and many of our, you know, partners across the state have. Bruce, you shared on a couple of your slides, you know, LACOA has signed on, as well as GMHC and others. So we've heard from our partners that, and we've heard today that, you know, this could potentially be one of the next tools towards combating or fighting against HIV stigma, which is really powerful. So with no further ado, I am going to read the bio for our next presenter, Roscoe Boyd. Roscoe Boyd moved to the New York City area after graduating with a BA in music from Morehouse College. A Detroit native, he joined Teach for America and taught in the Bronx while earning his Master of Science in Teaching, and in Brooklyn, where he pursued his passion to serve in the nonprofit sector at a college prep program in East New York. Roscoe consulted in New York City public schools, then moved to Washington, D.C., and became the Dance Institute of Washington's managing director. After discovering a natural ability in sales, he soon became a top seller at Brooks Brothers. Living with HIV for 17 years, Roscoe's story was featured in Callan Lord Community Health Center's annual report in 2016, and he became a spokesperson for the HIV Stops With Me campaign. Today, as an insurance broker focused on nonprofits, his mission is to help nonprofits reduce operating costs, yielding more dollars for social good, and he continues active community engagement through multiple means. Thanks for joining us today, Roscoe.
Thank you for having me, Karen. Can you hear me?
Yes, we can.
Okay, excellent. So my role today is really as someone living with HIV and having dealt with years of stigma, isolation, feelings of worthlessness, and representing a population that today among which we're seeing a crisis. African American, gay, and bisexual men, or men who have sex with men. Some of the messaging regarding the epidemic in our communities is really around how we can rest easier because we are not poisonous when it comes to being undetectable. In our communities, there is an association, as we've seen most recently in the news, of HIV being something that is not something we talk about, but certainly something that can lead to a sense of isolation. From my perspective, it's time that we begin to tell everyone the truth. Bruce talked about it a bit earlier in terms of what it means to be an unsophisticated consumer. And in many instances, I've been viewed as an unsophisticated consumer by virtue of the color of my skin. So speaking very specifically about the crisis in our country, and the thing that we have the power to change is the way we're able to step out of our comfort zones and look at science through a different lens, from a human perspective. I believe that we need to address the concerns and the fears that underserved populations that have higher infection rates are facing, and what their perspective is, and working from that perspective to meet their needs. The CDC has reported that within a lifetime of a gay or bisexual black man, 1 in 2 will become HIV positive. That's an alarming statistic, and there are things that we can do about it. We're seeing that in the media. There are things that we can do to change the tide and how things are playing out in our society. A huge part of this is the role that providers can play in messaging. When working with underserved communities, using data and moving from a very clinical approach to a more human one is one of those ways. Dr. Cespedes spoke about earlier, speaking with her patients in a way that helps them arrive at conclusions and helps them work through their own concerns and fears with regard to their potential HIV status, HIV positive status. From my perspective as a consumer, it is the medical professional's responsibility to get you to trust me. And trust is something that's earned and built off of a sincere desire to establish relationship and not just be seen as a number. Earlier, someone spoke about sex being a part of being human, and it is often that we are detached from the humanity and the need to understand what goes into someone's behaviors not just from a psychological perspective, but some of the social determinants that increase our risk of infection. Regarding African American men, between the ages of 17 and 24, we are seeing a greater rate of infection than any other group, and not just in this country, but in the world. There are many social economic factors that increase that rate, and a part of it is the plight that we experience, that we see playing out across society. Some of it is the way that society views the sexual appetite of black men. The truth of the matter is that black men have no greater sexual appetite than any other group of men, particularly as we compare ourselves to white gay men. That is something that is proven, and that is something that we can start to erase in terms of a myth about the sexual proclivities of black people in general. Some of the social economic factors that play into this is that we have a lack of access to health care, right, or a lack of trust in the systems that are made available. Again, I go back to the reality that healthcare providers can do more to reach out to us and become proximate to our issues and our concerns. Another challenge is the exclusivity. Black men tend to be intimate with other black men, and like everyone, we seek to find love and intimacy and express that through barrier-free sex. To be loved is something that society does not always grant us, and it can be seen in the way that we're treated with regard to the fear, the stereotypes with regard to criminalization, as well as the way we are thought about in the media in general. It is certainly something that we need to make sure is understood in terms of our lives mattering in this context as we move forward with U equals U, and finding ways to treat us fairly, particularly as it relates to information regarding our own health. I believe Bruce talked about that a little bit earlier when it comes to the unsophisticated consumer. That leads me to my next point in terms of the basic assumptions that we need to address. Historically, there has been a distrust of the medical establishment, and this is something we need to acknowledge. We need to acknowledge also the social constructs and beliefs that contribute to that. And sometimes those things play out in ways that practitioners may be unconscious of themselves. And so it's important that in dealing with this particular population, of which I am a member, and other underserved populations, that we're able to look at things through an objective lens and recognize that we bring our own beliefs and assumptions to the table and really check those and check in with ourselves about them. There's something really powerful about the potential of U equals U, specifically from an underserved community. It does help to eliminate the fear of transmission. It also helps to eliminate any feelings of shame regarding your status. This is the power of being able to open up a dialogue of honesty. And if we're using it in a way where we're helping people understand not just that they're not poisonous, but that in not being poisonous and seeking care, they're not only helping themselves, but helping their communities, we can realize and unlock an even greater potential for this campaign. Medication is a form of protection, but we have to encourage people to feel good about themselves and protecting themselves before we can talk about them protecting others. We finally want to encourage open and honest dialogue, and then look at this as a defining moment. It's a push forward. It's a push forward for getting more people into care and accessing the tools that are available. And it's also a push forward so that we can begin looking at resolving and solving the epidemic, not just from a prevention perspective, but from the perspective that there is the ability to find a cure. And the more we're able to control this epidemic within populations that are underserved and help them understand what the ramifications of this are, the better we're able to look at using more resources, financial resources, to end the epidemic by finding a cure. Thank you very much.
Great. Thanks so much, Roscoe. That was great insight. We really appreciate it. So I'm going to introduce our next speaker, Katrina Bolivlenkoff. I don't know, Katrina. I'm getting better. I'm getting better with last name pronunciation. Ms. Belovelenkoff is the director of the Lower East Side Harm Reduction Center, a program of the Alliance for Positive Change. She's currently serving on many committees and planning bodies, as well as advisory committees. To name just a couple, she is co-chair of the New York State AIDS Institute Ending the Epidemic Drug User Health Work Group, as well as she serves on the New York State Department of Health AIDS Institute Consumer Quality Advisory Committee. Katrina's activism is in support of consumer engagement and ending the epidemic initiatives has a personal story. In 2011, Katrina was diagnosed with HIV, which reinforced her passion to address the administrative and public health challenges that impact the spread of HIV. She currently uses her story to advance her public health mission as a spokesmodel for the HIV Stops With Me campaign. And Katrina, I'll turn it over to you.
Okay, am I off mute now?
Yes, we can hear you.
All right, perfect. So thank you guys so much, everybody, for being here. And I, just kind of like to start with this general overall statement that U equals U means that loving me doesn't have to come with a prescription. And I think that's really important when we're talking about healthcare because there's no other disease where you have to take a pill in order to be able to date someone. And over years of whether it's been the development of science or fear-based messaging or sort of the limited number of tools in our prevention toolkit, that has kind of been the message when it comes to dating and love and relationships, is that dating someone is going to always come with condoms and medication. So let's see. All right, so this is kind of a little bit of what I want to talk about. There's kind of looking at science, criminalization, dating, and sex, which we've talked a little bit about, stigma, which I think has really touched as part of all of the panelists' conversation, and then really looking at kind of patient experience and messaging. So the HIV Stops With Me campaign, and that's just to give it a little plug for those of you on there who haven't had an opportunity to check it out, who may be medical providers or allied health professionals. So it's a campaign that's funded by the New York State Department of Health, by PLWHA, to other PLWHA, to help reduce stigma, promote treatment as prevention, and to create a community for us to really inspire and support each other that are living with these diseases. It's received a number of awards. The link at the very bottom is where you can find my video. If you take my name out and put in Roscoe's, you will be able to find his as well, and I'd encourage you to check out the campaign. And for those of you who do provide direct service, there is somebody on that campaign who will match every demographic of the people that you serve, women of trans experience, men of trans experience, people who are infected perinatally, people who are infected within the context of what they thought were monogamous relationships, and so on and so forth. There's a variety of racial and ethnic backgrounds, genders. So I really like to think that that there's something valuable in this campaign to offer for both patients and providers. So I also want to say that U equals U does not diminish the role of PrEP. I would never want to knock PrEP. I think that it plays an important part in our prevention toolkit moving forward. And I think, we acknowledge that most people I know living with HIV do not want to transmit HIV to their sexual partners. And because of that, we have already largely brought into treatment as prevention. And I think you've seen that especially kind of the emphasis in New York State as we see more and more people becoming undetectable. The other thing I think that we got from the very beginning from Brian's talk is that the research is there, but I don't think that the overall buy-in is. And I think that because the medical community hasn't completely bought in and that we don't have a good message coming out of our medical institution, that consumers and their networks aren't able to fully understand and endorse the message. And I'm in lots of meetings with people who are newly diagnosed and people who are long-term survivors of this disease, and they're confused. And if they've been in care for a really long time and they know that they're doing the right thing and they're taking the medication, and individual doctors here or there are telling them they're not detectable, and that means that they're not going to transmit the virus, but then they might hear something else from someone else, then I think that that disconnect among the medical community is really doing a disservice to people living with HIV. And part of that is I don't know that if you are outside of the infectious disease field that you really get a clear understanding of what undetectable means. I've had to educate my physical therapist, my dentist. I've worked with, trauma nurses, pathologists, different people that I run into over my life. And unless you're in our community, then there doesn't seem to be a really good understanding of what undetectable or even viral suppression is. One thing that really nobody has touched on, but I think is really important, is to remember that we are often criminalized for having HIV. And, this isn't something that's happening in small rural towns far away. Even here in New York State, there was a gentleman, David Plunkett, who spent 6 years in jail for biting a police officer during an arrest because he was considered to basically be his own deadly weapon. Luckily, his case was overturned, but that sends a scary message to people. There are still 24 states that have criminalization laws with respect to sexual contact, and 17 that still have laws on the books relating to spitting, biting, and blood exposure, even though, as we talked about earlier, that's not really, when Bruce mentioned, that's just not a thing that happens. It's gotten to the point where it's even needed the creation of organization like Zero Project to come together to defend the right of people who are wrongly prosecuted for their HIV status, whether it's been non-disclosure, potential, or perceived HIV exposure, regardless of actual transmission or infection. So I like to tell everybody that being in love is awesome and dating is terrible. And when you're looking to find someone and you're talking about bills and aging parents and kids from your first marriage and mortgages and all those kind of things, that having HIV creates another barrier in being able to find somebody that you can create a life with. So what U equals U does is that it helps eliminate that fear of transmission in serodiscordant couples and creates a space to date, to be together, to have open and honest conversation. And it's a reminder that we really do all deserve the intimacy of condomless sex. It means that women, whether me or someone else, if we want to make babies the old-fashioned way, that we have the right to do it. I'm glad that we got some information on breastfeeding. I think that's really important to share, but nobody wants to have a test tube baby unless you absolutely need to have a test tube baby, right? Most of us want to have that natural coming together and making a baby in hopefully a supportive, loving environment. And it also gives us the opportunity to educate our partners and to disclose our status. And I keep wanting to hit the button like I'm on PowerPoint, and I'm not. So I think doctors have been telling patients this individually for years. When I was living in Maryland in 2012, my doctor told me that as long as I was undetectable, I did not have to use condoms with my primary partner. I also am not a fan of the we're only as undetectable as our last viral load, because I know I'm doing the same thing, and I know that every time when I go back I am going to be undetectable. I have been since 2012, whether I've been seen quarterly at 4-month or 6-month intervals, that I trust that because I'm doing the right thing, I'm able to take care of other people who are important to me. I think a lot of us aren't using condoms, whether we're telling you or not, when we're in the exam room. At the last presentation, and I did this the other day at Columbia, and I said, I haven't used condoms since 2012, and someone else said, well, that's great. I'm really glad that you own that. I haven't been using condoms since 2009. And we're doing it, but if you're treating us with judgment and not allowing us to have conversations with you that promote harm reduction, and reinforcing that idea or stigma and shame, and if we're worried that because of what we tell you that it's going to change how you treat us, we're not going to be able to have those really robust conversations. I'm a big fan of the New York City Health Department's Bear It All campaign, that there shouldn't be anything that we can't talk about with you, and there also needs to be an understanding that even if it may be different, it's not weird, and even if you may not agree with it, that doesn't mean that it's something that we aren't going to continue to do, right? So I think the last point of my slide here is I always say that everyone has the right to put whoever or whatever they want in their bodies, that we're with you for 15, 20 minutes 4 times a year, that we need to have realistic conversations about what we're going to do for the 365 days when we're not in your office. I think somebody has already touched a little bit on the right to the information of U equals U. was this information given to me because I am a licensed clinical social worker? I have a master's degree. I've always maintained private insurance, and that I am worthy of this information as opposed to someone who's living in the South Bronx from whom maybe English is a second language, may have a fifth-grade education, or other sort of perceived challenges that we don't feel like they're a good candidate for being undetectable, so we don't want to tell them. Whereas I really think it's the opposite, where U equals U can be the carrot and not the stick, that it gives us the opportunity of something to work towards, as opposed no meds equals death, or the fact that we're only doing this to take care of other people. We're doing this to take care of ourselves, and we're doing this to be able to have open, loving, supportive relationships. Stigma, we have historically been dehumanized. We have been treated as vectors. I think, even now we are well monitored, but once you become undetectable, you can really fall off the radar. And for some people, I think that's okay, that they're all right moving to biannual visits. But I think if we really want to work within U equals U and make sure that it's accessible to everybody, that we can't stop being important once we become undetectable, that there still needs to be that check-in, whether it's care coordination, whether it's the mid-level picking up the phone to check in on somebody, maybe it's calling the pharmacy to make sure that somebody is still picking up their meds every month, that just because you're undetectable can't be you've reached some treatment point, right? You can't transmit the virus to anybody else. Now go along on your way. Roscoe mentioned that we do have years of unlearning to do, from media portrayals and fear-based high school sex ed. I always tell everybody what we learned is that, if you got HIV, your penis or your vagina was going to fall off and you're going to die. I know Charles King has heard that analogy before and likes it, so I feel the need to continue to keep using it in all of my presentations. But it's really true. We are often pigeonholed by our transmission risk. There's a hierarchy of HIV infection, right? If you're someone who got it like me, who thought they were in the context of a monogamous relationship, then, you're okay. If you were somebody who was born with it, then there's no blame there. If you are someone who contracted HIV through sex work or through a party and play scene where you may not have known who you were infected by, or that you were an injection drug user, then that understanding compassion isn't frequently there. And, there's a nuance of living with HIV within our psychosocial well-being that can't be based upon the way we were infected. And, I like to tell people I got into this field the wrong way. I was a HIV care manager for 5 years before I became infected with HIV. I wasn't diagnosed until very late in the game because I don't think anyone actually thought to test someone who looks like me. So I was diagnosed when I had meningitis. I was in the hospital. I was pregnant. I ended up losing the baby because I don't think my body could support both of us. And it's an important message to providers that, there is still a need for universal testing. There still is a need for, sort of that TB model to diagnose and treat right away, and not really kind of make a judgment call of who is ready for treatment and what kind of treatment and information that they are ready for. We have internalized so much of this stigma and shame that it touches on every single thing we do. It affects disclosure. It affects how we live our lives. It affects our sense of responsibility to the community. And, when we did this presentation at Columbia the other day, someone asked me, well, what does this mean for disclosure, and what is your responsibility for disclosure? And my answer was, it depends, right? You want people to disclose as often as they feel comfortable. But it's also not my job to take care of your health. I don't tell you to wear a seatbelt. I don't tell you to take your high blood pressure medication. I don't tell you to stop smoking. I don't tell you to look both ways before you cross the street. Those are things that maybe your doctor might tell you, but when I'm interacting with you on a day-to-day basis, that I'm expected to take care of my health and you are expected to take care of your health. If I am in a long-term committed relationship, I do want that person to know my status. If I get hit by a bus, I want that person to be able to tell the emergency room physician, hey, when she's in here for this broken leg, she's going to be here for a while. She's also going to need her HIV taken care of. But I think it changes that when you're in a setting, if you know that you are not able to transmit HIV and that you are taking the appropriate mechanisms to care for yourself, whether it's in terms of pregnancy prevention or STI prevention, that there is the ability to be able to push back and say, you know, look, this isn't all on me anymore. This is a community conversation, and if I'm going to take my meds and I'm going to be undetectable and I'm going to do what I have to do to make sure that I'm healthy and the people around me are healthy, then you guys on the other side of the table have to do the same thing. And I think finally what I'd like to end with is just, you know, I always say when I was on the other side of the exam table, when I was working with people in a clinical professional capacity before I became a patient, there was a lot of things that I got wrong. It wasn't because I had bad intentions. It wasn't because I didn't have all the scientific clinical information. It was because I just wasn't living it. And I don't think that you have to be living with HIV to be an expert in this field. I think it helps to have people living with this disease who are leaders and are pushing the ball forward when it comes to what's happening in this field. But I think what it really comes down to is that we constantly need to listen. We need to be okay with being told that we're doing something wrong, and we need to be okay with changing the landscape and re-navigating this as information becomes available, because we really want to treat our patients as the experts in this field and the experts of their own lives. And back to you, Karen.
Great. Thanks so much, Katrina. That was really great, good insights, and thanks for sharing so much of your experience. Before we move on, I am just going to do a couple of housekeeping updates. I realize that we are a bit over our time. We do have 3 questions kind of in queue that I will hold on to before I introduce Dr. Robert Remian. What I would like to do is just do a check-in with our panelists and see if you wouldn't mind staying about 10 minutes or so after to help us answer questions for anyone who might be willing to stay on and listen, and for the recording purposes as well. If we receive additional questions, what we can do is keep those and work with our panelists to get them answered and share the answers when we also share the recorded version of our WebEx. So any presenters who are unable to stay for about 10 minutes after. All right, it sounds like we're good. So I'm going to move forward and give Dr. Remian an opportunity to kind of provide some key points and summary points, if you might. I have a little bio here I'm going to read. Dr. Robert Remian is a professor of clinical psychology and director of the HIV Center for Clinical and Behavioral Studies at the New York State Psychiatric Institute and the Department of Psychiatry at Columbia University. He is the clinical director for mental health in the Northeast Caribbean AIDS Education and Training Center, faculty mentor for HIV Center postdoctoral fellows, and clinical supervisor to psychiatric residents in training, and serves on numerous NIH review panels and local, national, and international advisory groups. Dr. Remian has been involved in HIV volunteer work, clinical work, and community mobilization and advocacy since the early 1980s, and he has developed a large and diverse portfolio of domestic and international research projects focusing on the intersection of prevention and care. His research includes the development and testing of evidence-based behavioral interventions. Thanks so much for joining us.
Thank you. Thanks, everyone. I'll try and do this in a New York minute. Great panel. Starting off the top, Charles King reminded us how powerful this tool is. I think he called it a weapon. This is really important, exciting information, the reality of non-transmissibility when there's persistent viral suppression, and the belief that this may address stigma, liberating people from self-imposed stigma, and can facilitate a change in how others view people living with HIV. Ben Choi provided us with the evidence showing us that the evidence is quite clear. There is negligible to zero risk in the context of viral suppression. He pointed out the naysayers and people who talk about blips or STI or genital fluid being different from plasma viral load. But even with that, the data are still very clear that people just don't transmit when they are on persistent treatment. As he emphasized and others did, sustained viral suppression is key. Gina Brown nicely pointed out the caveats and the differences with mother-to-child transmission through breast milk in particular, and the complex details of the biology of transmission via breast milk. but she pointed out how it's a balancing act of the risks and benefits, and that may look different in different contexts in different parts of the world. Don Desjardins pointed out the injection drug use in HIV transmission, the difficulty of knowing with absolute certainty, but that there's been a tremendous reduction in transmission in this population, both because of use of syringes, clean syringes, the use of clean syringes and not sharing, and also reduce sexual transmission in the population. But he pointed out nicely that reducing social stigma and self-stigma is what's important, even if we don't know if it's absolutely true for transmission risk, but the importance of taking pride in protecting their own health and the health of their injecting and sexual partners. Michelle Cespedes gave us the provider perspective, reminding us of the importance of the first U, long-term viral suppression, the importance of helping people ensure access to care, getting full benefit of the medication, the importance of addressing mental health issues, interpersonal issues, and all the structural barriers and other social determinants of health so that people have successful and consistent care, the importance of health literacy, and for people understanding the role and importance of ARVs, and having good, honest, open communication between doctor and patient. Bruce reminded us of what a defining moment this really is, and showed us the wonderful campaign that's going worldwide. Not only does Sustained on Art improve people's lives, but it provides an additional incentive for getting on and staying on treatment. But he pointed out the reality that so many people just don't know this fact, that they cannot transmit if they're on persistent treatment. So they are unnecessarily carrying the burden of believing they are infectious. And so we need to get the message out, and we need to shout it loud. Roscoe Boyd pointed out and reiterated the importance and value of not feeling poisonous, and thus people living with HIV can rest easier. Again, time to get the message out, and the importance of providers using a human approach. And he also reminded us of the reality of the historical distrust of the medical establishment, but that U equals U is such an important and valuable message. And Katrina Balolenkov told us about the HIV Stops With Me campaign, which is a wonderful campaign. It's so supportive and inspiring. And she reminded us of the reality of criminalization laws, that we need to advocate for change where these laws still exist. But that the U equals U can eliminate fear in discordant couples, the ability for safe intimacy, including reproduction, and how it can facilitate status sharing, but now that it's out there and it's on all of us. Let me just add a couple of comments in terms of my own clinical experience working with HIV positive, HIV negative, and different couples. It really, truly is very reassuring. It reduces a lot of anxiety for people living with HIV, and can also be reassuring for seronegative partners. That does not mean that at the individual level, people won't have questions about what it means for themselves. I think as providers or counselors, we have to first of all provide the information and then engage in a dialogue of how the person understands the facts and let them ask questions and discuss what level of risk the person is comfortable with for themselves. Bottom line though, give them the information. Let's not hold back on this exciting message of U equals U. To me, the most important message is actually a dual one. The bottom line, suppressed viral load is good for the person living with HIV and their own health, and it's also, as a bonus, it's good for the risk to partners. So the support and encouragement of treatment and viral suppression sustained is on all of us. Let's get the information out. Let's inform people so they can make their own personal choices. And I would just say that regarding STIs that Ben touched upon, people should fear the STIs for the sake of the STI, but we should not hold HIV hostage to the fact that other STIs also exist. And finally, let's not discriminate who we are willing to give the message to. While health literacy matters, it should never be used as an excuse for not messaging the reality of U equals U. It is up to us to tailor the message in culturally competent ways, but the message has to be put out there, and this must be done through an equity lens. Bruce and others have been leading the way. It is now up to all of us to carry the message forward. I'll stop there. Thank you.
Wow, that was impressive. Thank you so much for providing such a great summary and really touching on many of the key points that we heard today from our excellent panelists, as well as some of your additional insights. That's really great in terms of our ability to wrap up our discussion for today, and really gave me some things to think about as we move forward. So I am going to move us right into our question and answer portion for another few minutes here. Maggie did put the instructions back up on these slides to show you how to submit a question through the chat function directly to Maggie. A couple questions did come through as individuals were presenting. One of the first questions that we have, we believe, is for Dr. Gina Brown. Gina, the question is, our belief is that infants are given ARTs after birth. How long are they on ARTs, and would keeping infants on ARTs while they're breastfeeding offer more protection if the mother chose to breastfeed?
So when you're looking at the data that I showed you, so the data that looked that was the original discussion from International AIDS Society, the women were randomized into the woman getting treatment versus the infant getting treatment, and there wasn't a big difference between the rates of HIV with them. So do we know if it's any better if mom's getting treatment and the baby's getting treatment? We don't know if it's any better. And so I guess my major point from this is we don't have the data yet that says that in a place like the United States, where your chance, if you haven't been infected by the time you're born, that your chance of getting infected with breast milk is higher than your chance, if you're breastfeeding, is higher than your chance of not breastfeeding. So we're not in a place yet where we can say that even treating both mother and treating baby would make a difference. We just don't have that data yet. So right now we're still in the place where it's safer to not breastfeed.
Great. Thank you so much.
Will we ever be there? Maybe.
Right.
I can't say that we'll never be there, but I think we just need the data.
More to learn. Thank you. And thank you for the question to one of our listeners. So the next two questions are ones that I believe are not really attributed to any one presenter. So one of them was really talking about, many of you mentioned this idea of viral load blips. One of the questions related to this is, in the case of these quote-unquote viral load blips, is there a known viral load threshold for transmission? And then I guess the second part of that question would be, what would you say to someone who is concerned about viral blips?
Oh, is that to me?
I open it to any of our panelists that may have a comment in response.
So in general, in the research arena, viral load of less than 1,500 is considered low enough to be unlikely to have transmission or HIV transmission. In the clinical sense, a blip is really a viral load in the several hundred range. I would say in about the 200 to 500 range. I think most providers might ignore a viral load of less than that, or if there's some sort of problem in their lab or something of the sort that can explain it, they might not be too concerned with something in the less than 200 range. But a consistent viral load above that may be concerning, that the patient's virus is on the way, kind of outsmarting how the medication works. But viral load really in the 1,500 range is 1,500 or higher, I should say, is considered to be more likely to be transmittable.
Great. And Bruce, did you have something to add to that?
No, I think Michelle did a great job with that. I mean, we just know that from the research that what's considered a viral blip isn't anything to be concerned about, and there isn't any data to suggest that those blips would lead to transmission. So it's not anything that folks should be worried about unless they continue to increase over time, and then you might talk to your doctor, as Michelle said, about changing medication. There might be that might be cause to look into different regimen.
And this is Gina. I was just going to say that, by definition, it's sort of a blip as it goes up and it comes back down. if something's staying up or continuing to go up, that might be a reason to think about changing medication. But the other thing is there's some thought that even during those periods where there's like slight increases, that maybe you have a flu or something like that, are probably not virus that's particularly strong or infective either.
Very interesting point. Thank you. All right, and our last question submitted today has to do, I believe, more so with messaging. So again, something that's open to all of our panelists to consider in a response. The question is, the difference between viral suppression and undetectable. How would you explain it?
So I think, this is Katrina. I've answered this a little bit from a social point, and someone else I think can speak to it from a more medical point that has the license behind their name. But when I'm talking to lay people about what it means, or when I'm trying to explain it to a friend or someone who has no exposure to HIV, I almost explain like being undetectable is kind of like the concept of being in remission, right? That you kind of have something but you're still healthy. And that's largely because people have had more exposure to cancer, and Susan G. Komen and different movements like that, that while it's not exactly the same thing, and I wouldn't from a medical perspective say it is, but it introduces the concept that you could have had something and have been sick before, but now you're really okay.
Thank you for that. Anyone else? I think that really gets at something to consider. All right, so those are all the questions that we actually received through the chat function. There might be some shy individuals. If you kind of bring this home and think through it and have additional questions, feel free to email myself or Margaret Brown or Tracy Hatton. We'll be happy to get you in touch with any one of our panelists or help you to find the answers to what you're looking for. I want to give our panelists one more opportunity. If there's any last phrase or word or anything that you'd like to get out there before we end today, I open it up to you. Are we tired? I think we might be after this great webinar. So I've been receiving some chats that just say how fantastic this experience has been, how worthwhile it has been to have this opportunity to join this discussion and learn more about both the clinical evidence as well as the messaging, the potential impact on stigma, and opportunities to move this message forward. So I just want to take the opportunity to once again thank all of our panelists for sharing their 2+ hours with us today, and to all of our listeners and individuals who joined us today on a Monday. Thank you for your time. We will be sharing the webinar and likely posting it on our Ending the Epidemic website, so we'll certainly reach out to our listserv and make sure people are aware of when that happens. And we thank you again for your time today. Thank you.